Good evening to everyone and welcome to today's session. Chai Pe Charcha with Dr. Murli Bhardwaj for your NEETPG 2019. Harendra Pratap Singh, Commandant, Harsha and many more who are all online. We had been discussing neurology in the last few sessions. Can the online students punch? How is the voice loud and clear? Can you please punch? Welcome to Prajakta Bhagat and many more. Now, in the general medicine, endocrinology, what are the hot topics for the NEETPG examiner based on the analysis of the questions in the last 15 years? Adrenal gland and the conditions in adrenal gland, mainly hyperadrenalism, etc., etc. Then thyroid, SIADH and diabetes insipidus, carcinoids, pheochromocytoma, pituitary gland conditions, multiple endocrine neoplasia, hyperparathyroidism, prolactinoma, parathyroid gland, acromegaly, metabolic syndrome, insulinoma, and hypoparathyroidism, and very important, diabetes. These are the sweet 16 topics you should get ready before you face the NEETPG examiner when it comes to the general medicine. Now let us make the great beginning. The adrenal reserve. How do you want to test the adrenal reserve is a very important question. If you infuse the ACTH, it is a way by which you can discover. But one point you should always remember, in endocrinology, there are only two kinds of tests. Can you please give me the board? Can you give me the board? So there are two kinds of tests in endocrinology, predominantly. Can you get me one pen, please? Marker. Yeah. Yeah, I have the marker. So you should remember stimulation tests and suppression tests. Just like NEETPG examiner, if you have abundance of knowledge and you prepared very well, what will he do? He will try to use a suppression type of MCQs. Single liners, very difficult to answer. How much silicon is there in first week question kind of questions. In spite of using suppression test, if the suppression is not happening, it is a sign of a hyper-functioning gland, basically. Second, stimulation test. आप कुछ भी नहीं प्रिपेयर होके एग्जाम गया, एग्जामिनर ने easiest क्वेश्चन दिया, पोटैटो खाए तो तुम क्या बनोगे? पोटैटो बनोगे? वो भी आप आंसर रॉन्ग किया, उसका मतलब there is nothing filled in your brain. So, stimulation tests, in spite of stimulation, if the increase in the hormone is not happening, that means it is a hypo-functioning gland, is what you need to remember. So, a hypo-functioning gland is proven by doing a stimulation test and proving that in spite of stimulation, the gland is not producing anything. A hyper-functioning gland is suppressed, and in spite of suppression, the gland is continuing to produce, means it is a hyper-functioning gland, is what you have to fundamentally understand. So very happy to see today online 133 students. Very good. बहुत खुश हुआ Mogambo. Can you come back? So we should remember we should remember that typically the best way to check the adrenal reserve is by stimulating it with ACTH. अगर ACTH से stimulate करे तो two situations can happen. What are they? The serum cortisol level continues to be low if it is a primary adrenal insufficiency. It continues to be low if it is a secondary or a tertiary adrenal insufficiency. पहला primary adrenal insufficiency का मतलब क्या होता है? Adrenal अगर cortisol produce करना है तो पहला adrenal should be intact. If you get a tuberculosis of adrenal or Addison's disease of the adrenal and adrenal got destroyed, then you can't produce the corticosteroid. That situation is called primary adrenal insufficiency. What is meant by secondary adrenal or tertiary adrenal? अगर adrenal काम करना है तो ACTH आके adrenal को stimulate करे तो adrenal steroid का तैयारी करेगा. अगर उस pituitary में दिक्कत है, ACTH is not getting produced, that is causing the adrenal to fail. That is called secondary adrenal insufficiency. Whether it is primary adrenal or secondary adrenal, पहला क्या है? Serum cortisol is low because it is failed. क्यों fail हुआ? Adrenal के वजह से fail हुआ, मगर ACTH तो continuously production हो रहा है, उसका मतलब है primary adrenal insufficiency. So वहाँ ACTH high रहेगा serum में. Whereas secondary adrenal insufficiency is a situation where your cortisol is low, even if you stimulate with ACTH also it is low, but the plasma ACTH levels are by themselves are very low. So that is basically called the ACTH stimulation test is what you need to basically remember. So if the cortisol level fails to increase the response to the exogenous ACTH, it means the problem is there fundamentally in the adrenal itself, that is primary adrenal insufficiency. But if the ACTH is able to increase the cortisol levels which are otherwise low, that means problem is not with the adrenal, but the problem is with the pituitary. That's the reason exogenous ACTH will be able to change the low level of the cortisol to high level of cortisol. That is called secondary adrenal insufficiency. Basically, whiteboard is whiteboard. We can never understand unless there is a whiteboard. That is how from childhood we have become. Can you please come to the board? Yeah. So, from childhood we are habituated to learn from the board. So, this is your pituitary, here is your adrenal, and pituitary produces ACTH that is supposed to stimulate the adrenal to produce the cortisol. Adrenal has failed. What are the two possibilities? Either there is a destruction in the adrenal which is called primary adrenal insufficiency. There is a destruction in the pituitary which is called secondary adrenal insufficiency. How will you differentiate these two? In both the situations, cortisol levels are low, basically, fundamentally, basally. But in primary adrenal insufficiency, ACTH is continued to get produced by the pituitary. So, there is a high ACTH if the problem is primary adrenal insufficiency. But if it is a adrenal insufficiency because of the pituitary, then ACTH levels are low, which is called secondary adrenal insufficiency. Now, if you happen to give exogenous ACTH, what will happen? If it is a primary adrenal insufficiency, cortisol remains low in spite of giving exogenous ACTH. Because adrenal itself is destroyed in primary adrenal insufficiency. Whereas if it is a secondary adrenal insufficiency, if you give exogenous ACTH, then it will be able to, all that exogenous ACTH will act on the adrenal which is still intact in secondary adrenal insufficiency, and your cortisol levels will improve. That is how you differentiate. So very easy to remember. So the main purpose of the can you come back? Yeah, is the ACTH is to do two things. It is to differentiate between primary and secondary adrenal insufficiency. That's the main thing that the exogenous ACTH will be doing, is what you have to remember. Now, what is Wolman's disease? Wolman's disease. Prajakta Bhagat is saying, awesome sir, but I am not very happy. I would have finished this half the time to explain, but my mind is working somewhere else. There was another emergency. There is one of the patients posted for the coronary angiogram. So I need to rush to that place only to give a reassurance. I'm not doing angiogram, but I'm the primary physician of that patient. So just now before I started the class, the patient called, please come now to just to put a couple of words to my father who is going to the primary angioplasty. I promised the patient that, yeah, definitely I'll come and be on his side to reassure. So that is acting on my mind. Otherwise, this should not take so long to explain you. Anyway, Wolman's disease. What is this? So you should remember that it is a lysosomal storage disorder, autosomal recessively transmitted, and the problem is lysosomal lipase, which is fundamentally deficient. How does Wolman present clinically? It's an early presentation. There is a vomiting, steatorrhea, failure to thrive, abdominal distension, splenomegaly, and liver failure. Very important is adrenal calcification, and unfortunately survival typically less than 1 year. That is the Wolman's disease. So if you look radiologically, doctor, you can see in the adrenals the presence of the calcification. This question can come as an image-based question in the tomorrow's NEETPG, which you should remember. Once more, you can see in the adrenal, you can find the presence of calcification. The moment adrenal calcification is there, you should remember Wolman's disease. So it is autosomal recessive. All recessive disorders are completely penetrant and fully expressive. I think you know very well. Autosomal dominant and variable penetrance and variable expressivity. And the problem is in which important enzyme, doctor? Lysosomal acid lipase, which is fundamentally deficient. So this is once more histologically you can see all that fatty vacuolation and the presence of the calcification is what you can classically see in a patient. What is the typical clinical story of Wolman? A 21-year-old at 3 months of age, failure to thrive, malabsorption, diarrhea, weight loss, ascites, hepatosplenomegaly, and on examination, lysosomal acid esterase deficiency is the one which is classically found. Then there's a severe malabsorption and abnormal foamy macrophages, which is the classical feature. Now, what are all those endocrinological syndromes where you find obesity as a feature is a very important question. Cushing's, all of you know. Pickyvickian is that fat man with obstructive sleep apnea. Prader-Willi syndrome also, you have obesity, is what you need to remember. So what is Prader-Willi? What is 5-6 points you should remember? So I hope you are all enjoying UMedico app notifications, and another couple of hours, one more version of the UMedico is coming, where you start getting, for all the reminders you have set up, the notifications start coming to you, so that you are all in the buzz of the preparation. So the problem in Prader-Willi, once more, you bookmark this slide also in UMedico, favorite question of the examiner. Chromosome 15. There is a hypothalamic pituitary abnormality, hypotonia, hyperphagia, morbid obesity, and behavioral problems, cardiomyopathy, obstructive sleep apnea, seizures. They're all the problems in the case of the Prader-Willi is what you need to remember. This is a beautiful question, doctor. Without a question of congenital adrenal hyperplasia, NEETPG nahi hoga, nahi hoga, nahi hoga. You have to master this topic. If you do that, you are pocketing one mark in your pocket. We had a more extensive discussion on this congenital adrenal hyperplasia in the DNB video library in UMedico app, in the AIMS past 15 years, and the high-yield topic discussion past 15 years video library. You have a more extensive video discussions, but I will cut short this for today. So, in congenital adrenal hyperplasia, you have hyperkalemia and hyponatremia. That is the combination which is typically seen in salt-losing adrenogenital syndrome is what you need to remember. Fundamentally, how does it happen? Progesterone, this is one very important table, doctor. UMedico app में आप bookmark करके notification set करना, reminder. If you know this table, you know everything. Progesterone become deoxycorticosterone, become corticosterone, become 18-hydroxyprogesterone, become aldosterone, and that is the place where you have 21-alpha hydroxylase. Similarly, 17-hydroxyprogesterone become deoxycortisol and cortisol. There also you require 21. अगर 21 hydroxylase की deficiency हो जाए, क्या होगा? Basically, aldosterone is not produced, cortisol is not produced, मगर progesterone बनेगा 17-hydroxyprogesterone as usual, and all that excessive 17-hydroxyprogesterone जाके androgen बनेगा. So इसके वजह से क्या हो जाता? Excessive androgens will be there, and that lead to development of a virilizing feature if it is a female baby, and excessive growth of the genital organs if it is a male baby. That is what you need to appreciate. But aldosterone कम होने के वजह से क्या हो जाता? 21-alpha hydroxylase deficiency. Aldosterone is required for retention of sodium and potassium. Sodium. So that is the reason they will lose the sodium into the urine, and in exchange, what does normally aldosterone does? Retention of sodium and loss of potassium and H plus into the urine. In this case, क्या हो जाता? The sodium retention doesn't occur, sodium is lost into the urine and potassium is retained, and that lead to hyperkalemia in case of the 21-alpha hydroxylase deficiency is what you need to appreciate. So 21-alpha hydroxylase is also called salt wasting type of the congenital adrenal hyperplasia is what you need to remember. Then there is one more enzyme called 11-alpha hydroxylase. इसको salt retention and hypertensive type of CAH बोलते हैं. So that is the reverse will happen in case of the 11-alpha hydroxylase. Typically there is too much of production of aldosterone. and that lead to development of salt retention and hypertension as the presenting features is what I want to underscore. So 21 alpha hydroxylase may, there's a decrease of cortisol, decrease of aldosterone, increase of androgens and ACTH. Why ACTH is increased? Because when the adrenal is not producing steroids, low steroids will stimulate the pituitary to continuously produce ACTH, and that makes the adrenal to get hyperplastic. So that is called congenital adrenal hyperplasia. It is salt wasting type where patient has hyponatremia, hyperkalemia, hypotension, cardiovascular collapse. In the case of the males, that excess androgens in 21 alpha hydroxylase lead to the precocious puberty, and always high androgens can lead to oligospermia. Similarly, females there will be ambiguous genitalia, virilization of the genitalia. They're all the features of the 21 alpha hydroxylase deficiency is what you need to ultimately remember. So very good to see 187 online viewers on this wonderful evening. December 15th, exactly 3 weeks, 21 days more. You can do a lot of things in this next 21 days. Those topics which are falling short, just go to the video library, quickly review, go through the notes on the UMedico app, and then set up the reminders, and also you can write comments. You can record your voice for every note slide and help your other classmates to prepare well. And there are also cross notifications. If your friend whom you are following happens to add a comment, then all the followers will get a notification. So it's a good community, strong community of preparation together. The UMedico app. Patient has got arthritis, skin hyperpigmentation, hypogonadism. What is your diagnosis, doctor? Hemochromatosis is what you need to remember. Now, इस मौके पे I wanted to discuss one important point with you. Why hypogonadism? Can you give me the board? Yeah. In the case of hemochromatosis is a favorite question of the examiner. All of you know, pituitary produce FSH and LH. And in the testes, LH will lead to the testosterone production, and FSH will lead to the spermatogenesis. Spermatogenesis, all of you know very well. Suppose if you take a Klinefelter syndrome guy, there is a hyalinization of his seminiferous tubules. इसलिए this person will have a low testosterone and azoospermia. Whenever you have low testosterone, इस situation को कहते हैं hypogonadism. मगर when testis is not able to produce testosterone, what will happen to the pituitary? Pituitary starts producing increased LH because pituitary is still intact. And what is the situation called? What is LH called? Gonadotrophic. And what is happening? Hypogonadism is what you need to remember. Whereas in hemochromatosis क्या होता है? All the iron deposition goes and destroys the pituitary, those cells which are producing the LH. If the LH is not there, then the testis, though it is intact, cannot produce testosterone. So, a low testosterone is called hypogonadism. मगर किसके वजह से हो रहा है hypogonadism? Low LH के वजह से. क्यों हो रहा है? पिट्यूटरी को डिस्ट्रॉय किया है ये पूरा हाई आयरन लेवल्स. So this is called as hypogonadotrophic hypogonadism is what you see in the case of the hemochromatosis. Whereas Klinefelter में जो दिखता है उसको कहते हैं hypergonadotrophic hypogonadism is what you have to ultimately remember. Yes, Ravi asked a very reasonable question. Sir, will testis will not become Iron Man ka testis? No, that is what examiner will ask a question. Hemochromatosis का hypogonadism कौन सा variety का होता है? ये hypergonadotropic hypogonadism होता है, but not hypogonadotropic hypogonadism. That is what you have to emphatically answer, one of the favorite questions of the examiner. So 6:30 बजे तक 200 छात्र आ गए क्लास को. खुश हुआ Dr. Murali Bharadwaj. So call some more of your friends. Please extend this subscribers numbers by promoting this channel on all your social circles and share it so that we can have a classroom with 20,000 students across the country. Oh, maza alag rehta hai, and I am waiting for that. A bigger election winning. So hemochromatosis में the extra iron deposits in organs and tissues that get damaged. Two types of hemochromatosis होता है. Primary, secondary. Primary is hereditary, secondary is not obviously genetic. So the gene mutation called HFE, easy to remember, high FE, you can remember. HFE gene mutation is primary. Whereas secondary, frequent blood transfusion. Suppose if he is a patient of hemophilia, thalassemia, etc. Frequent transfusions lead to iron overload state, which is called as secondary hemochromatosis, is what you need to remember. So hemochromatosis, what are the important features? There is a skin pigmentation with that characteristic metallic or a slate grey hue. Lot of melanin and iron in the dermis will be found. Classically, it is the face and neck extensor aspects of the lower forearms, genital areas, on the scars, classical locations of deposition. And all this excess iron will go and deposit in the heart and lead to restrictive cardiomyopathy and cardiac failure. And there is a development of the arthritis in the case of the hemochromatosis is what you need to remember. Now, what are the various testicular dysgenesis syndromes is my question to all of you. Cryptorchidism, poor sperm quality, hypospadias, they all come under testicular dysgenesis syndromes, which you need to remember. So whenever any environmental factors or endocrine disruption lead to the testicular dysgenesis, sometimes even chromosomal abnormalities like 45X or point mutations of 46XY, all this will disturb two things in testis. One is Sertoli dysfunction, Leydig dysfunction. Sertoli dysfunction will lead to impaired differentiation of the germ cells, and that reduce the semen quality with sperms inadequate, and it can lead to development of testicular cancer. Whereas decreased Leydig cell function will lead to decreased testosterone levels. Because of that, in the embryonic life, testicular descent doesn't happen. So basically, for the testis to come from its Olympic heights in the abdomen into the ground level in the scrotum, in the embryonic life you require testosterone adequately. So that lead to testicular maldescent and hypospadias. So that is the reason cryptorchidism, poor sperm quality, hypospadias, they are all the part of the testicular dysgenesis syndrome is what you need to basically remember. Now, what are the various immunoprivileged areas in our body? Pehla, what is meant by immunoprivileged areas? Let us talk about it. So, Generally, our own self-antigens, our own immune cells don't go and attack them. Right? There is a way to recognize them. But there are certain locations where even though it is own self-antigen of your own body, still the immune cells will go and attack it agar usko dekh liye to. So what are those locations? Brain. Agar brain ka cell by chance honeymoon ke liye blood mein aa gaya to immediately it will elicit a lot of autoimmune reaction. Testis. There are some studies which have shown agar vasectomy kar rahe, some of the testicular content happen to seep into the blood, that will mark a lot of antigenic reaction, autoantigens, autoantibodies. Similarly, anterior chamber and the lens of the eye also, if their material happens to enter into the systemic circulation, there will be an intense autoimmunity against it, which is called as the privileged sites is what you need to remember. And these cells are all destroyed by apoptosis and cytokine secretion. So the brain, the fetus, in the eyes, the cornea, testicles, placenta, articular cartilage, they are all called as immunoprivileged sites. Malignant adrenal mass. What is the most common reason for it? Always it is a metastasis in adrenal, which is the most common source of the malignant adrenal mass. So this is the liver. Very easy. CT, MRI, थोड़ा anatomy right में क्या है, left में क्या है मालूम हो गया तो it's no big deal to crack these questions. Here you have adrenal gland. This is the kidney. This is the spleen on the left side. Here you have another kidney. एक किडनी के ऊपर ये नॉर्मल एड्रिनल यहाँ दिख रहा है आपको, मगर यहाँ के एड्रिनल में मेटास्टेसिस आके बैठ गए. That is the reason this adrenal got enlarged, and from there is this metastasis in this case. From the lung cancer they have come. There's a reason always a bronchogenic carcinoma patient, don't forget when you order for a CT scan, please kindly do some of the upper abdominal cuts also, is what you need to write on your requisition slip for the radiologist. Why? Because bronchogenic carcinoma can have adrenal mets and you would love to see whether there are any adrenal mets. That is the most important purpose. There is hypertension with hypokalemia. So where do you see hypertension with hypokalemia is a very important question. We see it in Cushing's. Cushing is what? Excessive steroid. Because of that excessive steroid, you get hypertension. See, the steroids will lead to vasoconstriction. And there is a development of hypokalemia in case of Cushing. Because excessive steroids act like mineralocorticoids. What mineralocorticoids do? They retain the sodium and lose the potassium into the urine. So that is the reason that lead to development of hypokalemia. So hypertension with hypokalemia is a combination that you see in the case of the Cushing's. Primary hyperaldosteronism. Yahan bhi excess aldosterone, it leads to sodium retention and potassium loss into urine. That leads to hypokalemia. And you also see it in Liddle's. Abhi aa gaya hamara favorite question. Liddle syndrome kya hota hai? Just 1-2 points you should know about Liddle. That's all. It is an autosomal dominant condition. Collecting duct mein, there is one sodium channel. And that sodium channel in the collecting duct normally is responsible for reabsorption of sodium back into the body instead of losing the sodium into the urine. So this sodium channel gets a mutation which makes it to become hyperactivated. So that leads to excessive amount of sodium reabsorption, and all that excess sodium lead to hypertension. In addition, whenever you have high salt in your body, it will suppress your renin and aldosterone levels. So low renin, low aldosterone, hypertension because of hyperactivity of the sodium channel in the collecting duct leading to excessive sodium reabsorption is called as the Liddle syndrome. So the same channel which is causing excessive sodium reabsorption will also cause excessive loss of potassium and H+ into the urine. That is the reason you get hypokalemia, alkalosis, hypertension, low renin, low aldosterone. In case of the Liddles is what you need to remember. So how do the patients of Liddles basically present is a very important question. Severe hypertension, and because of hypokalemia and metabolic alkalosis, hypokalemia leads to muscle weakness. They also have polyuria, polydipsia, muscle weakness, low aldosterone, low renin levels. It is autosomal dominant, hence more commonly seen in elderly people. And blood pressure, in spite of giving spironolactone, will not improve. But if you happen to give triamterene or amiloride, which directly act on that sodium channel, which is hyperactive, they will go and inhibit it. Then the hypertension improves. This is what you need to know about the Liddle syndrome is what I want to underscore. So once more, doctor, whiteboard hota hai learning and teaching ka raja. You will only understand along with the teacher if you are having the whiteboard available. So doctor, once more, आप एक कलम पकड़ के आपके रूममेट को और स्टडी मेट इन द रीडिंग रूम को without any break in the mind, if you can explain, then you know the concept. Simple. Liddle syndrome, once more आपके लिए बोल रहा हूं. Liddle, Bartter and the Gitelman. If you are Dr. Murli Bharadwaj students, अगर एग्जाम हॉल में वो आ गए तो जंप करके आंसर करना. You should not do any mistake. So you have a glomerulus, Bowman's capsule, proximal convoluted tubule, and ascending and descending limb of loop of Henle, and finally collecting duct. In the collecting duct, you are having a sodium channel. Sodium channel will pull the sodium out of the tubular fluid and pushes the potassium and H+ into the urine. So because of the mutation क्या हो गया? This became hyperactive. Excessive sodium retain हो गया. High sodium will decrease the renin levels and the angiotensin levels and aldosterone levels. So these are all decreased because of this high sodium which got retained. And because potassium H+ are gone into the urine, you get hypokalemia and associated muscle weakness, and you get metabolic alkalosis because of the loss of H+ into urine. And how does spironolactone normally function? Spironolactone typically will make the aldosterone to not act on the, normally what aldosterone does, its job is actually to make this sodium channel become active, but in Liddles already it is active. So normally spironolactone inhibits aldosterone from activating this sodium channel. But here already patient has a low aldosterone. तो spironolactone देने से क्या होता? कुछ भी नहीं होता. You give triamterene, amiloride, how do they act? They directly inhibit this sodium channel. So this is hyperfunctioning, and this triamterene amiloride will come and inhibit it. So that is the treatment. So favorite question of the examiner. In Liddle syndrome, will spironolactone works or triamcinolone works? What is your answer like a parrot? Triamcinolone काम करेगा, spironolactone काम नहीं करेगा, is what you have to confidently answer in the tomorrow's exam. So doctor, end stage renal disease में hypo नहीं रहता, hyperkalemia is a feature in end stage renal disease. So much hyperkalemia that you need to, it is one of the indications for dialysis in end stage renal disease is what you need to ultimately remember. Now, there is a glucocorticoid deficiency. What are the features? It leads to weight loss. It leads to hypotension. It leads to fever. They're all true. But normally what is the role of steroid or mineralocorticoid? Retention of sodium, loss of potassium into urine. But if there is no steroid or mineralocorticoid, potassium doesn't go to urine, it remains in the body and that leads to hyperkalemia, not hypokalemia. That is what you need to remember. So, sodium retention, potassium loss is the feature of the glucocorticoid normally. But in the case of the deficiency, the potassium loss doesn't happen, so potassium has a tendency to get retained. So, I think there is no correct answer in this, all of them are the things that you see. So, glucocorticoid deficiency may weight loss, anorexia, myalgias, hypoglycemia, hyponatremia and anemia, eosinophilia. Eosino will be philia, not pinia. Lymphocytosis. Normally steroids lead to decrease of the lymphocyte count. But without steroid, lymphocytosis, eosinophilia are the features. Low blood pressure, postural hypotension, fever, ये सब रहता है. But still the answer is hyperkalemia here because glucocorticoid deficiency में hyponatremia होता है, but not that significant hyperkalemia. But mineralocorticoid deficiency है तो, yeah, you will also find hyperkalemia. That is what examiner is trying to impress on you. So, mineralocorticoid deficiency में hyperkalemia, hyponatremia रहता, मगर glucocorticoid में hyponatremia रहता, but hyperkalemia is not that much. That is what the examiner's point of view. What is the most common cause of Addison's? Is a favorite question of the examiner. Very good to see 208 online students. Shabaz is asking what is Gitelman. Shabaz you're already there on UMedico app. Just go to the DNB video library, Endocrinology in Medicine. There you have Liddle, Gitelman, everything fully discussed, doctor. All this evening 6 to 8 sessions is just to stimulate you to go back what is all abundantly available on the UMedico app video library that we have discussed days together, right? So, end of this discussion, you have to pick up, get inspiration to pick up 3-4 topics and khatam kar dena raat ko. So, that is the important point. So, question number 11, Thug of Hindustan, Sudipti. आप सब लोग एक बात भूलना मत. डॉक्टर मुरली बदमाश क्या बोला आपको? अगर टीबी ऑप्शंस में हो तो हम इस देश के वासी हैं जिस देश में टीबी रहती है. तो टीबी डॉक्टर, वेस्टर्न सोसाइटी में ऑटो इम्यून एड्रिनल इंसफिशिएंसी इज सीन, दैट इज कॉल्ड एडिसन. Actually, this is a wrongly framed question. It should be asked as adrenal insufficiency in India क्यों होता है? That is TB. Autoimmune adrenal insufficiency is Addison. But that's a way you should remember. So you find bilateral adrenal masses where the adrenals are bulky, lobulated contour is what you are able to see. This is a classical case of the tuberculosis leading to the adrenal destruction is what you need to remember. So what is wrong about Addison? Addison में hypoglycemia होता है and salt craving, they're all true, but not hypokalemia. Addison is insufficiency of glucocorticoid. Insufficiency में hyperkalemia होता, but not hypokalemia is what you have to emphatically remember. So whenever chronic hypoadrenalism is there, the low cortisol will lead to hypoglycemia, hypercalcemia. Calcemia hyper होता है, anemia, high ACTH. Obviously, when adrenals are not producing the steroid, the pituitary is stimulated to produce excessive ACTH. Every time ACTH is produced, it will also cause production of melanocyte stimulating hormone, and that lead to the development of the pigmentation is what you need to remember. Then hypoadrenalism के वजह से sex hormones कम हो जाता. So there is a loss of the body and pubic hair, loss of libido, amenorrhea, muscle wasting, thin limbs, they are all the features. And hyperaldosteronism के वजह से hyperkalemia, hyponatremia, they are the classical findings. Once more, हमारा primary secondary adrenal insufficiency आ गया. What is not a feature of secondary adrenal insufficiency? Beautiful question. Secondary adrenal insufficiency क्यों होता है? Adrenal destroy होने से या pituitary destroy होने से? Because the pituitary destruction. So, in secondary hypoaldosteronism, if the pituitary is destroyed, ACTH production ही नहीं हो रहा है. अगर ACTH नहीं प्रोड्यूस हो रहे तो मेलानोसाइट स्टिमुलेटिंग हार्मोन कहां से आएगा? नहीं आएगा. So इसलिए pigmentation is not the feature if the adrenal insufficiency is secondary to pituitary destruction. But if the adrenal insufficiency primarily is because of the adrenal problem, that low cortisol levels will stimulate the pituitary. Every time pituitary is producing ACTH, one MSH is produced, and that high MSH will lead to the pigmentation, which you see in the case of the Addison, is what you have to remember. So tell me all the causes for the primary adrenal and secondary adrenal insufficiency is a very important question. So you should remember, doctor, amyloidosis, autoimmune adrenalitis, adrenalectomy, hemochromatosis, metastatic neoplasia, TB, thrombosis, hemorrhage, etc. All destroying the adrenal gland. There are secondaries because of pituitary destruction, craniopharyngioma, empty cellus syndrome, histiocytosis, hypopituitarism, sarcoidosis, etc. and postpartum pituitary necrosis. They are all secondary adrenal insufficiencies is what you need to remember. So, primary versus secondary अगर आप देखें तो ACTH levels are high in primary, low in secondary. Cortisol levels are low in both, aldosterone is low in both, but potassium levels primary hypocortisolism में high रहता, secondary hypocortisolism में potassium levels are typically low. That is what you need to remember. Now let us look into why potassium levels are high if the hypocortisolism is due to adrenal, and why potassium levels are low in case of the secondary hypocortisolism because of the problem in the pituitary. This requires an important discussion, right? Definitely this question is going to come, doctor. Potassium levels in primary versus secondary hypoadrenalism is a very important debate. First, let us take primary hypoadrenalism. Where is the problem? Pituitary is there. Adrenal is destroyed. When adrenal is destroyed, steroid production is diminished, and even mineralocorticoid production is also decreased. So, when both of them are decreased, what will happen? Low mineralocorticoids will lead to hyperkalemia and hyponatremia. That is what you need to remember. Yeah, again. Now, second situation. Pituitary is there, adrenals are there, adrenals are intact. But pituitary is destroyed. Because of that, ACTH is not produced. So, if you take adrenal is supposed to produce what? Steroids and what? Mineralocorticoids it is supposed to produce. Mineralocorticoids it is supposed to produce. Only for steroid production you require ACTH to come and stimulate. Mineralocorticoid production, you don't need ACTH. What is a stimulating factor for the mineralocorticoid, doctor? The serum potassium level itself is a stimulating factor. If serum potassium levels are high, it will come and tell the adrenal, hey man, what are you doing? My levels are high. What are you doing? Then immediately adrenal produce the mineralocorticoid. That mineralocorticoid in turn will flush this potassium into the urine, and that lead to caliuresis and potassium levels will come down. So that is the reason kya ho jata? In case of adrenal insufficiency, which is secondary to the pituitary problem, potassium levels are low because of the caliuresis caused by excess mineralocorticoid production, because adrenals are still intact to produce this mineralocorticoid is what you need to remember. Whereas primary hypoadrenalism में adrenaline ही गड़बड़ हो गया. पोटेशियम हाई हो, लो हो, कुछ भी हो, मिनरलोकॉर्टिकॉइड प्रोड्यूस करने का दम नहीं है एड्रिनल में. द मोमेंट मिनरलोकॉर्टिकॉइड इज नॉट देयर, इट लीड टू हाइपरकेलेमिया. सो इसलिए हाइपरकेलेमिया इज अ फीचर ऑफ प्राइमरी एड्रिनल insufficiency. Hypokalemia and caliuresis is the feature of secondary adrenal insufficiency, is what you have to remember. Tomorrow's exam, definitely this question is going to come. Akkireddy Madhavi, Abhishek Vyas, Indumukhi, very good. Thank you for saying that it is a good explanation. There are certain जनरल मेडिसिन पढ़ने में भी मजा आता है, पढ़ाई देने में भी मजा आता है. SPM, oh my god. Forensic, oh my god. Yeah, even forensic is very interesting. There are some sexual disorders, paraphilias, वो सब कुछ poisoning, you know how to kill another person is very exciting. वो प्रिवेंटिव मेडिसिन में वो रहता ना, मस्किटो बैठेगा या खड़ेगा या एग फ्लैट लगाएगा या फ्लोटिंग लगाएगा, impossible. But still we should love to read them, remember them, bookmark them on the UMedico app, review them with only one single feeling and dream. मेरा नंबर आएगा नीट पीजी में आने के लिए, मैं एमडी जनरल मेडिसिन बनने के लिए, डीएम न्यूरोलॉजी बनने के लिए, कार्डियोलॉजी बनने के लिए. पहला वो फिल्टर रहता ना, ग्लूटियस मीडियस का नर्व सप्लाई क्या है, पाइरिफॉर्मिस का नर्व सप्लाई क्या है, वो सब खत्म करना पड़ेगा. देयर इज नो अदर वे व्हिच यू हैव टू बेसिकली डू. नाउ डॉक्टर, एड्रिनल इनसफिशिएंसी के वजह से क्या होता है? Low blood pressure, increased protein breakdown, decrease in extracellular fluid volume, patient become hypotensive, and potassium level क्या हो जाता है adrenal insufficiency में? There is a hyperkalemia. So sodium by potassium ratio क्या हो जाता है? Decrease होता है, increase नहीं होता. So that is a point of interest, is what you need to remember. Now doctor, Addison's disease. What do you see in Addison's disease? So you should remember hypotension, hyponatremia, hyperkalemia. They're all the features of the Addison's. Metabolic alkalosis कहाँ रहता? Hyperaldosteronism में रहता या hypo में रहता? Hyperaldosteronism. Hyperaldosteronism में. So when mineralocorticoid, glucocorticoid excess बनता है, that lead to retention of sodium and loss of K plus H plus into urine, loss of H plus into urine lead to metabolic alkalosis. एडिसन में क्यों होता है? नहीं होता. एडिसन में होता है ऑपोजिट ऑफ मेटाबॉलिक एल्कलोसिस. वो क्या है? माइल्ड मेटाबॉलिक एसिडोसिस इज द फीचर ऑफ एडिसन, इज व्हाट यू नीड टू रिमेंबर. So tell me the various causes for normal anion gap metabolic acidosis, doctor. Whenever there is any diarrhea, GIT causes, pancreatic fistulas, renal tubular acidosis, Addison is one important cause. Don't forget. Once more examiner is going to ask you, अगर metabolic acidosis है तो what type of metabolic acidosis है? High anion gap or normal anion gap in Addison? What is your answer? It is a normal anion gap metabolic acidosis. Similarly, carbonic anhydrase inhibitors also will lead to normal anion gap metabolic acidosis, which is hyperchloremic metabolic acidosis, is what you need to ultimately remember. Conn syndrome में क्या होता है? Conn is hyperaldosteronism. So obviously, once more you know the story. Hypertension, hypernatremia, hypokalemia because of the excess mineralocorticoids, but not edema. This is a beautiful question that requires a debate. So why edema is not a feature? And if edema is there, it is not Conn's. It is not Conn's. It is not Conn's. Why? Because all of you know that what is the definition of primary hyperaldosteronism is a very important question. Primary hyperaldosteronism क्या होता है? Always primary, secondary. Primary पूरा endocrinology में दो ही चीज होता है, primary, secondary. Suppression test, stimulation test. Hypo, hyper. Very easy. Practicing endocrinology मजा आता है. Because the endocrinologist, one side you have thyroid, another side you have infertility also nowadays is endocrinological domain. And all our life is because of what? Our little thyroid, our pituitary working. If it stops working, our adrenal stops working, we are done for the day. Pack the bag, go to the heaven. So that is the reason endocrinology is very, very interesting subject. Primary hyperaldosteronism क्या होता है? If the adrenal is having an adenoma that is producing excess aldosterone, and this is called as primary hyperaldosteronism. Secondary क्या होता है? Suppose you have congestive heart failure. अब बोलो, congestive heart failure में heart is not able to pump sufficient amount of cardiac output. That decreases the renal plasma flow. That will make the kidneys juxtaglomerular cells to produce excess renin. Increased renin cause increased angiotensin, that lead to increased aldosterone production. So high aldosterone occurring because of any condition which is decreasing the intrarenal blood flow and the intravascular volume contraction, because of that जो aldosterone बढ़ेगा, इसको कहते हैं secondary hyperaldosteronism is what you need to remember. So congestive heart failure में क्या रहता? Fetal edema, pulsating jugular, and ascites. All these are the features of congestive heart failure. So if edema is there, if the aldosterone is high, what is the type of aldosteronism it is? It is secondary hyperaldosteronism. So to call it as a primary hyperaldosteronism, what is the important part of definition? It is not due to edema. It is not due to congestive heart failure. It is not because of the high renin levels. It is because a adenoma thought, let me produce a lot of aldosterone. So, इन लोगों में प्राइमरी हाइपरएल्डोस्टेरोनिज्म में रेनिन के वजह से एल्डोस्टेरोन बढ़ रहे हैं और रेनिन के बिना भी बढ़ रहे हैं. Without renin only, aldosterone is high. Without edema, without any secondary stimulation only, adenoma is producing excess aldosterone. That is the reason what is important in case of the primary hyperaldosteronism Conn syndrome, a high aldosterone with a low renin without edema. That is the definition of Conn syndrome. For a secondary hyperaldosteronism में edema रहता, high renin रहता, high aldosterone रहता. That defines the secondary hyperaldosteronism is what you have to ultimately remember. So doctor, 223 online students is a wonderful feat of achievement today evening. Ranjit is saying, sir, we listened to your class, looks very easy, sir, but used, but we forget and confuse later. Don't confuse later. Come on. Confusion is a sign of weakness. What are you? You're all that strong, logically driven, wonderful students. So शांति से एक कागज लेके, एक कलम लेके, अपने दोस्त के साथ बैठ के, इसमें ये पॉइंट है, इसमें ये पॉइंट है, वो हार्ट नीट बुलेट्स को निकाल के 2-3 फ्रेंड्स के साथ चर्चा करो. You will remember it forever. Logical things, यूं आपके इंट्राविनस, इंट्राथीकल एडमिनिस्ट्रेशन हो जाना, मगर ये सिंगल लाइनर्स, न्यूमेरिकल्स, क्रोमोसोम नंबर्स, उसके लिए आप यू मेडिको ऐप में नोट्स में नोटिफिकेशन लगाओ रिमाइंडर का, वो आपको नोटिफाई करते जाएगा. ओके डॉक. नाउ डिक्रीज प्लाज्मा रेनिन. वंस मोर फेवरेट क्वेश्चन ऑफ द एग्जामिनर. अभी फटाफट आंसर करो. प्राइमरी हाइपरएल्डोस्टेरोनिज्म में रेनिन लेवल्स आर डिक्रीज. इसको आंसर करने में कुछ कंफ्यूजन है क्या? नहीं होगा, नहीं होगा. यू आर ऑल वंडरफुल स्टूडेंट्स ऑफ डॉक्टर मुरली भारद्वाज. मगर इसमें एक पॉइंट पूछा, बार्टर सिंड्रोम. चलो इसके बारे में चर्चा करेंगे. बार्टर क्या होता है? द होल स्टोरी इज इन द नेफ्रॉन फिजियोलॉजी. Highest number of questions in physiology. Without nephron physiology, there is no NEETPG exam. You have a proximal convoluted tubule. यहां bicarbonate का reabsorption होता है. That is the place where acetazolamide basically acts. Then you have the descending loop of limb of Henle. This is the place where your mannitol, isosorbate, all these osmotic diuretics basically act. Then you have the thick ascending limb of loop of Henle. इस जगह पे आपको सोडियम पोटेशियम 2 क्लोराइड का चैनल है, co-transporter. How does loop diuretics act? Furosemide or some, they all act on this and inhibit it. Bartter is that situation where without loop diuretic only, congenitally their sodium, potassium, 2-chloride मर गया. उसके वजह से it is like they are continuously like taking loop diuretic. Like every day every minute it is like living on furosemide. So loop diuretic like situation is fundamentally the Bartter syndrome is what you need to appreciate. Then you have a sodium chloride co-transporter which lead to the sodium retention. And thiazide diuretics basically act to inhibit that. And Gitelman syndrome is like taking every minute thiazide diuretic. उनके पैदाइश से sodium chloride channel is dead, not working. So that is the problem in Gitelman. Then you have the Liddle syndrome. That is the place where your potassium sparing diuretics are working and there is an epithelial sodium channel which become hyperactive. Gain of the function mutation is called in Liddle. Then finally you have aquaporin channels where desmopressin will be working for retaining the water in case of from the collecting duct is what you need to ultimately remember. So generally what is the rule? Ranjit absolutely correctly said. Loop diuretics lose calcium. Thiazide diuretics retain calcium. So Bartter syndrome में भी क्या हो जाता? Urinary calcium excretion increases that lead to nephrocalcinosis. And there is a polyuria, polydipsia, and hypokalemia, metabolic alkalosis, mental retardation, growth retardation in the neonatal life. And the problem is in the thick ascending limb of loop of Henle, sodium potassium 2-chloride channel jo hai, that is the one which has undergone a mutation. But why they are losing calcium into the urine? Because there is a calcium sensing receptor which is abnormal and there is a development of calciuresis, calciuria in case of the Bartter is what you need to ultimately remember. So the question was, do you find how will be the primary plasma renin activity in case of the Bartter? Obviously Bartter is like taking what? A loop diuretic like furosemide and they are losing all their plasma volume into the urine. A low plasma volume will lead to high renin, high angiotensin and high aldosterone. So that is the reason they will have a high plasma renin, not a low plasma renin is what you have to ultimately understand. So what are all those drugs that can lead to a low plasma renin activity is my question to all of you. Beta blockers, clonidine, methyl dopa, they are the drugs that lower the plasma renin activity. So why do you find hyperpigmentation in Cushing syndrome? Easy question. Because of that high ACTH, which also lead to high melanocyte stimulating hormone, there is a development of hyperpigmentation in case of the Cushing's. So this is a typical patient of Cushing's where there is a lot of hyperpigmentation of the face and also that Cushing appearance is a classical feature. इस मौके पे I like to ask you a question. What is Cushing's disease? What is Cushing's syndrome? This is a very stupid terminology. Modern endocrinology doesn't recognize, but still entrance exams keep on asking it. So you should remember, syndrome hota hai excess ACTH production in the pituitary. That is hypercortisolism due to pituitary adenoma producing excess ACTH. इसको बोलते हैं syndrome is what I want to underscore to all of you. They have a very high mortality. All that excess steroid lead to psychosis, impaired memory, depression, anxiety, hypertension, dyslipidemia, overweight, muscle and skin atrophy and osteoporosis. They are all predisposed by that high steroids, which you see in the case of the Cushing syndrome. Now, doctor, hypertension, hypokalemia, hypernatremia, metabolic alkalosis. Where do you see is a very important question. Primary hyperaldosteronism. Whenever aldosterone levels are high, obviously metabolic alkalosis, hypertension, hypernatremia, hypokalemia. Easy to explain. It is also found in the case of the Liddle syndrome is what you have to remember. So, this adrenal cortex that produce aldosterone. High aldosterone lead to sodium and water retention. At the same time, H plus and K plus excretion also is increased. And all that water retention increase the plasma volume, that increase the cardiac output, and that increase the arterial pressure. In turn, the juxtaglomerular cells will identify that increase of the arterial pressure and the renin production becomes suppressed, and that in turn will make the adrenal cortex to stop producing high aldosterone. So this is the typical loop which you need to fundamentally remember. Primary hyperaldosteronism. What is the important criteria for you to make a diagnosis of this? As we already discussed, primary बोलने के लिए क्या होता है? Low plasma renin. Low plasma renin, because adrenal is continuously producing excessive amount of aldosterone without depending on the renin, and in fact renin is suppressed. So low plasma renin. Even if you dehydrate the person, normally when you volume deplete the person, what should happen? That should stimulate the renin production. So even if you volume stimulate the person, volume deplete the person also, renin production nahi improve hota. So that is a feature of primary hyperaldosteronism. High aldosterone will lead to diastolic hypertension, no edema. Even if you do volume expansion and try to suppress the aldosterone levels, then the hyperaldosteronism is no anymore suppressed, because adrenal adenoma is a crazy adrenal. It doesn't want to stop. Even if renin is not there, it is produced. So, in spite of volume, what is the fund of volume expansion? If you expand the volume in the plasma, you are trying to improve the pressure of the blood flow to the kidney, sensed by the juxtaglomerular cells. They are supposed to suppress the renin. If the renin is suppressed, you are expecting aldosterone to come down. मगर hyperaldosteronism of Conn syndrome किसके वजह से हो रहे हैं? Adrenal adenoma के वजह से हो रहे हैं. So even if you do volume expansion, even if you suppress renin, adrenal रुकेगा नहीं. Continuously it keeps producing aldosteronism. That's the reason hyperaldosteronism, which is not suppressed by the volume expansion. And because of hyperaldosteronism, what do you get? Metabolic alkalosis, not acidosis. That is what you need to ultimately remember. So once more, I will try to whiteboard is whiteboard, right? So whiteboard is always whiteboard. So doctor, let's remember it like this. किडनी के ऊपर एड्रिनल बैठा है, and typically in the kidney, the juxtaglomerular cells, they produce the renin. Okay. Now, because of the adrenal adenoma, किसी के बात नहीं सुन रहे adrenal in Conn's. It is continuing to produce high aldosterone. It is continuing to produce high aldosterone. So this high aldosterone, in turn, what is it doing? It is causing retention of sodium and loss of K plus and H plus into urine. And this high sodium in the plasma is making juxtaglomerular cells to decrease renin production. So, hyperaldosteronism with a low renin is the feature of adrenal adenoma. So, how we can prove this situation? First, you try to cause volume depletion. That is, you dehydrate the fellow. What will happen? If you dehydrate the person, the blood flow to the kidney diminishes. Normally, when the blood flow to the kidney diminishes, juxtaglomerular cells immediately are supposed to increase the renin. They will sense, hey, glomerular filtrate is low. They will immediately sense it and they produce increased renin. Magar, a high aldosterone produced by this monster called as adrenal adenoma are so high that even if you volume deplete also, juxtaglomerular cells bolega, अरे क्या बात कर रहे भाई, आप volume deplete किया, trying to make me to believe this lies and produce renin. How can I produce? Large amount of aldosterone वहाँ बैठा है. I will not produce renin anymore, it will say. So one stimulus for juxtaglomerular cells to produce the renin is a volume depleted state. But one factor which is suppressing the renin production is high aldosterone. High aldosterone suppressive effect is more than the stimulatory effect of the volume depletion. So that is the thing that you see when adrenal adenoma is operating. Got it? Now, second important fact. So that means volume depletion does not improve the low renin levels because the juxtaglomerular cells producing the renin are forever got sufficiently suppressed by the high aldosterone produced by the adrenal adenoma in case of the Conn syndrome is what you have to remember. The second situation baat karenge. If you do volume expansion, what is your expectation? Suppose if you expanded the volume, a person has got a large amount of volume. So high volume expansion is supposed to make the juxtaglomerular cells to decrease the renin and in effect lead to decrease of aldosterone. That is what you are expecting in a आम आदमी एड्रिनल. मगर कॉन सिंड्रोम में क्या बात है? कॉन सिंड्रोम का एड्रिनल एडिनोमा रेनिन बोलने से प्रोड्यूस कर रहे हैं क्या? नहीं, अपने आप प्रोड्यूस कर रहे. तू रेनिन को बढ़ाओ, रेनिन को कम करो, रेनिन का जूस पियो, रेनिन का इंजेक्शन करो, कुछ भी करो, aldosterone levels won't get affected. So volume expansion does not bring down the high aldosterone. Volume depletion does not improve the low renin. That defines the autonomous power of the adrenal adenoma in case of the Conn syndrome is what you need to remember. So this is a very important point that you need to appreciate. So how many of you want to become endocrinologists after this lecture? So you should be very sure. It's a very cool branch. You can, not many emergencies except severe hypertension of your adrenal suppressed patient. Otherwise, it's a cool branch. Now, doctor, what is the classical triad of very good Abhishek, DM Endocrinology, Manas Agarwal also DM Endocrinology. Excellent. Thank you Aparna for calling this great cell. Always remember, I'm not immune from compliments. Oh, mujhe pura evening will be a great evening if my students compliment me. Sir, aap bola, hum zindagi tamam yaad rakhenge. I suddenly met in the other day in the airport, one of our students, he is a plastic surgeon from Bihar. So suddenly we crossed each other, but I'm like a video teacher. I can't know the student, but students know me. Sir, aap mil gaye. Then we almost had half an hour. We just slipped into the coffee shop, had a long talk. He remembers every joke, everything that I spoke about 10 years back. So what a great happiness I had while returning home. So my day was done. So doctor always, the life is short. You should enjoy every minute, every moment. And the happiness comes when you are giving. Either you are treating somebody, you are sharing the knowledge. So your roommates, your benchmates, your classmates, they will all be waiting for your wisdom. They could not be able to attend a wonderful class, even if it is free. But still, if you can take a pen and paper and explain them, they'll be very happy. So hypertension, hypokalemia, suppressed plasma renin activity, this is the combination which you have to basically remember. So doctor, Conn syndrome, once more, you can see how favorite Conn ke bina. My name is Conn. You are going to get a NEETPG question, no doubt. So you have weakness because of hypokalemia, polydipsia, polyuria, but not anosarca is what you have to basically remember. Now, pseudo Cushing kahan hota hai? Pseudo Cushing. Alcoholic people also will have the typical Cushing-like appearance, which is called as the pseudo Cushing. So Cushing syndrome may you have ACTH dependent disease and others. So if it is a pituitary dependent, then you call Cushing's disease. And adrenal adenomas, adrenal carcinomas, इन सब की वजह से syndrome होता है, मगर जब वो pituitary dependent होता है, उसको disease बोलते हैं. That's the only difference. And alcohol can lead to Cushing's-like features, which is called as Cushing syndrome, pseudo Cushing's. First, for Cushing syndrome, what is a true statement? You should remember that in Men-1 syndrome, patients will have pituitary adenoma. That's the reason they will have Cushing's disease. What is a part of Cushing syndrome? Then azoospermia, where do you see? We see in young syndrome azoospermia, whereas sperms will be there, but their motility will be low. That is the situation in case of the cartigenars, is what you need to remember. So when there is aspirin intolerance, bronchial asthma, ethmoidal polypi, this combination, what do you call in ENT? Dr. Chandrasekhar gave a wonderful ENT review for all of you, Samton spared. Then cartigenars there is a ciliary dyskinesia sinus invertus. Young syndrome there's a hyperviscous mucus along with azoospermia is young syndrome. So cystic fibrosis is all due to that abnormal mucus. Cartigenar you have ciliary dyskinesia, bronchiectasis, sinusitis and situs inversus. And young syndrome there is a sinopulmonary disease and azoospermia. And churg-strauss syndrome you have asthma, fever, eosinophilia, vasculitis and granuloma. The combination is called churg-strauss, as all of you know very well. Now, what is the most common cause of Addison's disease in India, doctor? हम इस देश के वासी हैं जिस देश में टीबी रहता है. Cushing syndrome commonly is caused by syndrome there are many causes. Any cause is a syndrome, can cause syndrome. But disease is when it occurs because of the high ACTH from pituitary. So it is the ectopic adrenal hormone production is the common cause. So disease versus syndrome. Pituitary tumor के वजह से हुए तो disease बोलते, and the causes, any cause is called as syndrome. So of all, what is the most common cause of the Cushing syndrome? It is all those iatrogenic steroids, the quacks in the villages. A quack Sinu has given, for anything he will give steroid. Pehla steroid deke baat karega. So that excessive exogenous iatrogenic steroids are commonly responsible for diabetes, Cushing syndrome is what need to be remembered. So what you don't see in Cushing's? Cushing में hyperglycemia, diabetes, glucose intolerance रहता, hypo नहीं रहता. Hypertension, psychosis, hypokalemia, they're all the features of the Cushing. Patient is having hemoptysis, Cushingoid features. There is no dexamethasone suppression, lack of dexamethasone suppression. What is the underlying cause is the favorite question of the examiner. So you should remember, doctor, favorite question of the examiner. A CA lung leading to ectopic ACTH production, there is no dexamethasone suppression. So now I am going to make you champion in this topic, doctor. Favorite question of the examiner. Why a hypercortisolism occur? Either a tumor in the adrenal cortex or because of a pituitary producing excessive ACTH which is stimulating the adrenal, that can be the cause, or ectopically lot of ACTH is produced. So ACTH dependent, adrenal dependent. Two things leading to hypercortisolism. If you look at serum cortisol, urine steroids, in all the three, the ACTH dependent situations are Cushing's disease and ectopic tumor. Cushing disease means pituitary adenoma. And ACTH independent situation is adrenocortical tumor excessively producing the corticosteroids. In both the situations, the serum cortisol, urinary steroids levels are typically increased. But serum ACTH levels, if it is an adrenal tumor responsible for the excess steroid, all that excess steroid will suppress the ACTH levels in the pituitary. So ACTH levels will be low in case of adrenocortical insufficiency. But ACTH levels are high when it is pituitary disease or whenever it is ectopic tumor is what you need to remember. अभी आप ACTH stimulation test कर रहे हैं. Normally stimulation tests are for what? Hypoproduction, not hyper. So इसलिए इसको भूल जाओ. Metapyrone inhibition and ACTH stimulation, if you take the two, they will show an exaggerated response, typically in case of the Cushing's disease. Cushing's disease में pituitary is already producing excess amount of ACTH. So if you do ACTH stimulation or metapyrone inhibition, then if it is a Cushing's disease, it will show exaggerated response. But what is important is dexamethasone suppression. अगर आप dexamethasone लगा दिए तो that high dexamethasone will come and inhibit the excess ACTH produced by the Cushing's disease, that is pituitary adenoma. But it will not have any effect if the hypercortisolism is because of the ectopic ACTH or adrenocortical tumor. In these situations, there will be no suppression. Suppression कब होता? If you give excess dexamethasone, if it is a pituitary adenoma leading to the hypercortisolism is what you have to remember. Once more, doctor. Board is board. Let's come on board about a dexamethasone suppression को हम खत्म करके निकलना है, right, doctor? Otherwise, these are the things that constantly stand as a stumble block in our mind. Medicine is an interesting subject, right? यहां पिट्यूटरी है जनाब, और यहां एड्रिनल है, यहां लंग्स है, लंग्स से ectopic ACTH because of a mass in the lung, ectopic ACTH is produced. Patient is having Cushing's syndrome, excess steroids. So, is it adrenal excessively producing? Is it pituitary high ACTH? Is it ectopic ACTH? अभी समझने की कोशिश कर रहे हैं. If you give dexamethasone, high dexamethasone is known to go and suppress the ACTH production. Even if it is pituitary adenoma, it will go and suppress the ACTH production by that. So, the hypercortisolism becomes normal cortisol. But a high dexamethasone, in case of adrenal adenoma, if it goes and suppresses the ACTH production by the pituitary, still the adrenal adenoma doesn't care for it, and it continues to produce high cortisol. So, it is not suppressible. Similarly, high dexamethasone can suppress ACTH production by the pituitary but not by ectopic ACTH. इसलिए hypercortisolism continues to be hyper if it is the ectopic ACTH responsible. So, dexamethasone दिए तो suppression of cortisol production किस situation में होता है? खाली pituitary adenoma के वजह से हो रहे तो then you will get suppression. But if it is from the adrenal cause or an ectopic ACTH produced from the lungs, you don't get suppression. That is what you have to emphatically remember for the tomorrow's exam. So, doctor, very good to see 213 online students. Please don't forget CuroChat, CuroChat. YouTube में सर्च में टाइप करो CuroChat. Please subscribe to this channel and share it to all your family members, friends, everybody. Here we are uploading a lot of patient education videos. Just afternoon, I uploaded a video on how to manage the menopausal hot flushes. Very common gynecological problem. पर gynecologist obstetricians बहुत busy रहते, large queue बैठता. इंडिया में कहाँ टाइम मिलता? देखो मैडम, आपको हॉट फ्लैशेस क्यों हो रहा है? बोले तो ईस्ट्रोजन कम हो गया. इसके लिए क्या क्या कर सकते? Unfortunately, as doctors, we do very good clinical work, but we don't get time to explain the patient the problem that he is having. So, on behalf of all my fellow doctors across the world who are doing wonderful job, I thought of coming up with around 5,000 videos on the common clinical problems the patients are expecting to get the answers from the doctors. Very common question होता है, अल्ट्रासाउंड में स्टोन निकला, इसके लिए ऑपरेशन जरूरत है या नहीं है? What is your बोलो ना डॉक्टर? That's what commonly people call. Coronary angiogram हो गया, हार्ट अटैक के बाद डिस्चार्ज होके मैं घर जा रहा हूं. When can I restart the sexual activity? Very common question asked by the patients. But doctor साहब को टाइम भी नहीं मिलता. As busy cardiologist, you don't have time to think about your own sexual activity, and you don't have time to explain the patient when he should resume his sexual activity. That is the reason common questions, common answers, 2 to 3 minute videos. I will appreciate even if you can record. Nowadays smartphone hai to record a 3 to 4 minute video and please send it to us and we will upload it into the CuroChat channel, with which we can help a lot of patients. Speak some common tips that you want to talk to the patient in regional language, Telugu, Malayalam, Kannada, Hindi, and upload. And that is a real great help we will be doing to the patient. So please go to the CuroChat and subscribe and invite all your friends to come to YouTube CuroChat channel, CuroChat. Now doctor, a child has ambiguous genitalia, no hyperpigmentation, normal BP, but 2.5 centimeter phallus. Gonads are not seen. Mullerian structures are present. What is your diagnosis? Beautiful question. So there is one important slide I am going to show you and explain you. Don't forget, this is one slide that you need to bookmark in your U-Medico app. There are some females who are born with a masculine looking external genitals, though they are having ovaries. They are called pseudo-hermaphrodites. And in congenital adrenal hyperplasia, so XX chromosome, genotypically female, but there is ambiguous genitalia because of the hypertrophy of the clitoris is what you are able to classically see. So where do you see hirsutism? You should remember Cushing syndrome, congenital adrenal hyperplasia, which is masculinizing with excess adrenal androgens, and Steen-Leventhal polycystic ovarian syndrome, you have hirsutism. But testicular fibrillizing syndrome may absence of axillary and pubic hair is the classical feature, is what you need to remember. So all causes of hirsutism, you should be sure. What is the most common cause of congenital adrenal hyperplasia? How does it present? So it will be a virilizing congenital adrenal hyperplasia. So it presents like a female pseudo-hermaphroditism is what you need to remember. So female pseudo-hermaphroditism can occur because of two reasons. Excessive fetal androgens as in congenital adrenal hyperplasia. Which type of congenital adrenal hyperplasias are virilizing? Don't forget doctor, 21 and 11. Similarly, if the mother is having any androgen secreting ovarian tumor or any androgenic drug, that also lead to female pseudo-hermaphroditism is what I want to underscore. This is the slide I want all of you to bookmark in the U-Medico app and set up a reminder, you should be sure. Male XY hota hai, SRY positive, SRY gene positive. That lead to the formation of the testis. In the testis, there is a Sertoli and a Leydig cell. Sertoli cell produce anti-Mullerian hormone, which lead to the Mullerian duct regression. So fallopian tubes or sub, they don't develop in male. Testis produce Leydig cells. They produce testosterone. Testosterone acts on the Wolffian duct and make Wolffian duct to produce vas deferens, epididymis, seminal recycle. Directly testosterone will do that. Whereas testosterone, by the action of the 5-alpha reductase, become a dihydrotestosterone. And this dihydrotestosterone goes and acts on the genital primordia, genital tubercles, urethral folds, and labioscrotal swellings. And the fusion of the urethral folds will lead to the formation of penis, penile urethra, and the scrotum. So dihydrotestosterone kiska influencer hai? Penile production, penile urethral production, and scrotum production. Whereas testosterone directly is an influencer of Wolffian duct derived structures, that is vas deferens, epididymis, and seminal recycle. Have a clarity. Examiner every time will catch your leg, neck, everything only on this Examiner is like an anaconda. It will come to catch you. You should be ready how to escape out of anaconda. Then XX is SRY negative. It acts, there is a ovary, and in the ovary cannot produce anti-Mullerian hormone. Only testis Sertoli cells can produce that. That is the reason Mullerian duct develops. And from the Mullerian duct, uterus, fallopian tubes, upper 1/3 of the vagina is developing from the Mullerian duct. So Mullerian duct abnormalities होता है ना, Rokitansky, Kussner, Hausner syndrome, वो सब में किसका abnormality होता है? Upper 1/3 vagina doesn't develop, but lower 2/3 of the vagina develop still, and that lead to a blind ending pouch-like vagina. In case of the Mullerian abnormalities is what you need to remember. Then ovarian hormones, they typically act on the genital primordia, genital tubercle, and that lead to clitoris, labia minora, labia majora, and the lower 2/3 of the vagina is what you have to fundamentally remember. So that is a bit of story of endocrinology of the NEETPG. There are totally about 16 topics. Every day we will finish 2-3 topics, but all these topics once more are high yield topics in DNB and in JIPMA, PGI, AIMS. They're all available with complete video discussion, notes, everything in the UMedico app. So those who are first timers to today's evening, please do call our helpline, and they will give you a wonderful subscription where though our evening classes are free, if you pay to the subscription, that helps us to pay to the faculty and to the server and many things. So unfreeze your fingers, doctor, and let us go to the quiz now. So who want to win the quiz today? Right. Yes. Who want to win the quiz today? That's good. Now, can you go down? Should your answer, doctor, have you gone to the changed it? Yeah. That's good. Karthik, Kancharla, Indumukhi, Akkireddy, Madhavi, Rahul Khanna. So, without meeting you guys, yes. The life doesn't end without meeting you all. I too have become addicted to all of you. Shoot your answer, doctor. 241. Yes. Harry says Mullerian duct form. Yeah, I think Harry is right. Upper 2/3, correct. Yes. वही है, upper 2/3, lower 1/3 के बीच में फर्क है. Harry is right. Yeah. So Rocket Trader says D. Bernard Solier is a platelet dysfunction, doctor. Yes. 241. Mitul Hirani proposes C. Seema Vishwakarma says D. Very good. Tivya. Tivya is from Pondicherry. From which part of Tamil Nadu, Tivya, you are from? So, Akash Rai says C. Absolutely. Clotting time. Chronic liver disease may coagulation factors are diminished. So, clotting time is affected, not the bleeding time, which is due to platelet dysfunction. I'm surprised why you guys are still seduced by the option D. Yeah. Now, blood is stored in the blood bank. At what temperature is a very important question. Yes. What is the temperature at which blood is stored at blood bank? 242. Aruna Gangadaram is proposing, very good, Tivya is from Chidambaram, one of the most auspicious Lord Shankara's temple is there. That's good. So I can see most of you saying yay. Absolutely right. Which is a myeloproliferative disorder is my question to all of you. Should your answer, doctor? Myeloproliferative disorder, 243. That's good. I can see chronic myeloid leukemia, obviously. After splenectomy, what is the infection that you may get is the question. What is the infection, capsulated organisms that you may end up is a important question. Yes. That's good. Now, yeah. I can see most of you choosing H influenza, which is right. For the chronic myeloid leukemia, what is the drug of choice in your opinion? Yes, doctor. So, good. That's right. Most of you are saying imatinib mesylate. Absolutely. What is Philadelphia chromosome is a very important question. What is the numbers that you need to remember? Philadelphia chromosome. So very good. I can see between B and A. I have just typed the CuroChat YouTube channel. So please don't forget to ask all your family members, friends, cousins with a lot of patient education videos which we are uploading there. So it is a long arm of the chromosome 9 and long arm of the chromosome 22, as Karthik Kancharla rightly said. So this kind of questions only, doctor, exam में लिखने के बाद, I missed it. We keep saying. Now, you see in thalassemia major, what is except about it? 247. 247. Should your answer? In thalassemia major, what is except about it? Yes. Easy. Yeah. Sabyasachi, everyone is saying, you find microcytic anemia. Easy question. Which is not a hypercoagulable state out of all this. Question number 248. In fact, there is a more bleeding diathesis rather than hypercoagulable state. Please shoot your answer, doctor. After this class is over, I want all 220 of you to just go to the CuroChat YouTube channel and subscribe. And as a teacher, I will be very happy. And that will give a beginning for a lot of patient education video channel to become popularized. I can see all of you answering it as cirrhosis. Absolutely right. Elective splenectomy. Where do we do? Elective splenectomy, doctor. Should your answer? Yes. One strong answer. 249. Ravi is proposing Sickle cell. Is it sickle cell? Very good. Kartikeya is saying hereditary spherocytosis. Bajia. Hereditary spherocytosis may not only splenectomy, even at the time of splenectomy, you should also do cholecystectomy because the pigmented gallstones are very common in the hemolysis caused by the hereditary spherocytosis. Priapism can be due to what? Should you answer? In which situation you find the priapism is an important question. Yes. That's right. Aparna is right. Sickle cell has autosplenectomy because of infarcts. So I can see 250. Very good. Mithul, Hirani, Abhiraj, Paul. Everyone is proposing autoimmune hemolytic anemia. No. CML may there is a hyperleukocytosis. Because of that hyperleukocytosis, patients will develop hyperviscosity and that lead to development of the priapism is what you have to remember. Hairy cell leukemia, कौन सा जाति का leukemia है? B cell का, T cell का और NK cell का? बढ़िया question. Please answer, correct answer doctor, don't make me cry. Question number 251. Right. I can see Aparna, Indumukhi answering A. A good number of you. Anup, Chandran also. Sai Maunika, clean bowl. B cell tumor. Junker diverticulum. What is incorrect about Junker's diverticulum is my question to all of you. 252. Should you answer, doctor? Yes. Ravi is proposing B. Vipul Chaudhary is saying A. But Syed Mazur is proposing C. Beautiful. It is not pre-malignant. It leads to dysphagia, Killian's triangle. All of them are true. Cobblestoning of the colon. Where do you see, doctor? Should you answer? Cobblestoning of the colon. Where do we see? 253. Yes. I can see A by most of you. That's right. Crohn's disease. What is not true about the Crohn's disease? Tomorrow 9 to 12 p.m. there will be a NEETPG full scale grand test. Please log in into this channel at 9 a.m. and 12 to 2 p.m. I will be there to discuss some of the important questions. So all of you participate every Sunday. 9 to 12 is the test and 12 to 2 is the discussion of that NEETPG full scale grand test. So who among you are first timers to this today evening, doctor? Please punch. First timer attending today to this session. Yes. I can see most of you thinking it as D versus A. D is true that invasion of the lymph nodes is not a feature. All layers are involved. Skip lesions are seen. It can involve stomach and duodenum. They're all the true stories. Alia Ruhi, please don't forget us. All 365 days, free coaching dene wale hain hum. So, don't worry about forthcoming exam. We will be with you until you get the seat. So, please call our helpline number, which is mentioned below, and they will give you a subscription into UMedico app, the video library. That's good. So, colon in this given picture, you can see, what is this colon? Lead pipe like a colon. कहाँ दिखता है आपको? 255. 255. Should you answer? That's right. अगर आप स्किपिंग करना शुरू करें तो एनस से माउथ तक जा सकते हैं. क्रॉन्स आल्सो स्किप्स एंड रीचेस. अल्सरेटिव कोलाइटिस को स्किपिंग नहीं आता, इसलिए इट विल ओनली रिमेन इन कोलॉन, इसलिए इसको अल्सरेटिव कोलाइटिस बोला. राइट? सो वेरी गुड. Most of you are saying ulcerative colitis. Absolutely right. What is least likely feature in the Crohn's disease is an important question. 256. Shoot your answer, doctor. Least likely feature. So I can see Tiwari proposing toxic megacolon. Most of you are betting on toxic megacolon. Absolutely right. Fistula, skip lesions, transferal involvement, they're all Crohn's. कभी कभी smoking भी protective हो जाता है, but don't ask your patients to smoke. For which conditions smoking is protective is my question to all of you. Yes, doctor. Question number 257. Very good. Krishna Saumya is proposing A, and most of you are proposing A. Absolutely, for the ulcerative colitis, right? Then Barrett's esophagus कौन सा कार्सिनोमा का responsible underlying factor है? So, should your answer? Question number 258. I can see most of you saying adenocarcinoma. H. pylori के वजह से ये सारे चीज होता है except what? Where H. pylori is not implicated. Easy question. These are all FMGE questions. So हमारे quiz के लिए FMGE questions ले लेंगे. मगर some questions in FMGE are really good questions. If you are clean bowled, don't there is no surprise. Alia Ruhi is proposing carcinoid. Absolutely right. Traveler's diarrhea is caused by what? Should your answer? 260. Traveler's diarrhea. Bharati Gopal. I am meeting you first time today. So Bharati Gopal is from which place? What do you want to become? MD. Which speciality you want, Bharati? So I can see most of you answering A versus D. Indumukhi thinks D. No, doctor. Campylobacter, E. coli, they're all traveler diarrhea. Aspirin sensitive asthma में आप क्या देखते हैं? 261. So Bharati, you are from which part of this country and what is the MD you are dreaming for? Tell your classmates so that they don't compete you. So Nischal is proposing D, 261. Sansar Tiwari, Dr. Sansar Tiwari, पहली बार मैं आपका मुलाकात हुआ. So very good. Vellore, Bharati is from Vellore where CMC is there. So I think Bharati want, let me make a guess. She want to do MD gynecology obstetrics. Am I right, Bharati? So I can see most of you saying D. Absolutely. There will be no increased prostaglandins. That is not true, right? So rhinosinusitis, nasal polyposis, etc., they're all seen. In a patient with COPD, what is the best management option among those which have been shown to you? Yes. Very good. Bharati want to become MD radiology so that shadows don't lie. That is the rule. Very good. Radiology is like general medicine, very extensive. You have a radiology in orthopedics everywhere. Good. And a very satisfying division, radiology. Right? So most of you are saying yay. I'm very happy. Yeah, but low flow oxygen रहना. COPD में if you put a high flow oxygen, quit smoking is definitely true, but most important precaution is it should be a low flow oxygen. patient with smoking history, what is important? कितने सिगरेट पिया इंपॉर्टेंट है, सिगरेट पिया या बीड़ी पिया इंपॉर्टेंट है, फिल्टर वाला पिया विदाउट फिल्टर पिया भी इंपॉर्टेंट है, क्या इंपॉर्टेंट है? So 263, I see most of you wonderful pulmonologists of India are proposing duration is more important, sir. बचपन से पिया या प्रोफेसर बनने के बाद पिया? Duration, absolutely right. कितने साल पिया is most important. Hyperventilation leads to what? What is the outcome of it? Yeah, should you answer, doctor? 264. I want to see all of you coming tomorrow morning 9 to 12. The full scale NEETPG grand test. Ask your friends also to come and attempt. 12 to 2 we will have a discussion of the grand test. And all of you download UMedico app, enjoy notes, videos, quizzes, mock tests, all the features, and you have entire ज्ञान की भंडागार है UMedico app, which you can download. iOS में new version with new features of notes is coming another 1 week. Android में already आ गया है, so please do that. So most of you are saying hyperventilation lead to getting out the carbon dioxide is what you need to remember. Chest X-ray में आपको कुछ दिखाई दे रहे हैं. So a cancer pneumonia will present like this, where there is an associated pneumonic effusion. 265. Very good. Nischal is betting on bacterial pneumonia. What is the contraindication for ACE inhibitor, doctor, out of all this? 266. Good. 266. I can see, very good. Most of you are saying, except A versus B. Not in chronic renal failure, pregnancy, hyperkalemia, bilateral renal artery stenosis, they're all the contraindications for the ACE inhibitors, is what you should remember. Patient is on insulin, 4th stage CKD. What do you want to do with his insulin? उसका डोज बढ़ाना चाहते हैं आप या कम करना चाहते हैं? ऐसे छोटे छोटे वीडियोस बना रहे हम क्यूरो चैट में, पेशेंट एजुकेशन वीडियोस यूट्यूब में. आप भूलना मत, ये सेशन खत्म होते ही आप जस्ट गो टू द यूट्यूब. आई एम टाइपिंग द लिंक, so please don't forget. I should see 200 subscribers adding up into the Curo Chat channel, which is also our channel, where we are putting thousands of patient education, real case studies, real patient experience videos, where the patients talk how I lived with myasthenia gravis, what happened that evening when I had Guillain-Barré syndrome, how I am recovering from the myocardial infarction. We want patients to speak, and that helps a lot. The other patients who got the diagnosis, and you are all going to be the part of my mission. So please don't forget to go and subscribe and click on the bell mark also to get notifications of many more new videos on the Curo Chat channel. Helpful for all patients, right? So that's right. So always remember, doctor, suddenly midnight आपको call आ गया कि patient is dead in the ward, a renal failure patient. What is the reason? You are trying to give him a regular dose of insulin, and in fact a strict dose of insulin to maintain a strict glycemia. If you have renal failure, your insulin clearance becomes diminished. So that's the reason if you maintain a regular dose instead of decreasing the dose of insulin, the patient can end up in a hypoglycemic attack in the midnight, is what you need to basically remember. So doctor, which will help nephrolithiasis is my question to all of you. Right. Question number 268. Lot of times patients ask this common question, sir, स्टोन को प्रिवेंट करने के लिए क्या करना? अगर मैं कैल्शियम का खाना बंद कर दिए तो मेरा स्टोन इंप्रूव होता है क्या बोल के पूछते, राइट? सो क्वेश्चन नंबर 268, you will find all those small answers on videos on the CuroChat app. So Sansar Tiwari thinks low citrate or high citrate. Then I can see most of you attracted to D. Vanaparthi Vanishri is proposing low calcium. No, low sodium. You just this I don't have time to explain, but low sodium is a one. Low calcium, in fact, can have a contrary effects on nephrolithiasis because a calcium, if it is low in the diet, there is nobody available to sequester the oxalate. Agar oxalate is free hai to that lead to oxalate stone. So low calcium should not be too low for the patients is what you have to remember. Right. Samsung said, patient died again. That's right. So, what is absolute indication for hemodialysis? That's right. Commandant Jindabad replied it correctly. Absolute indication for hemodialysis. देखो, I say awesome questions आता है FMG में. Yes. 269. Shravani is proposing C, pericarditis. Abhishek is also saying C. Vanaparthi Vanishri is thinking hypokalemia. Come on, hyperkalemia. Vanishri, don't break my heart. So, absolutely. Abhiraj Paul is saying uremic pericarditis. Absolutely right. So, the last question for the today's evening. Most common cause of the glomerulonephritis. You should not forget, doctor. What is the most common cause for the glomerulonephritis? 278th question. I can see Nischal betting on PSGN. Chowdhury betting on, yeah, I can see a lot of you betting on A. But Swasti is saying crescentic. Okay, absolutely, wonderful, doctor. So, thank you once more for giving your great evening to Dr. Murli Bharadwaj and also entertaining your classmates. Yesterday, I could not take a class. We ran a video. Even then, around 150 students are there in the class. That shows, as a community, you also got addicted. एक दूसरे से बात नहीं करे तो दिन नहीं चलेगा आगे. That is the whole preparation, doctor. So tomorrow when NEETPG toppers आप बनने के बाद, we will have all of you to come together and have a snap together to remember that winter we all were the classmates on the Dr. Murli Bharadwaj Chai Pe Charcha classes. You should remember for the next 30, 40 years while you are practicing. So, thank you so much, wonderfully. And I am very hopeful and expecting currently 100 subscribers hai. Another 10 minutes mein 340 subscribers on the YouTube channel rehna hai. That is what I am looking for. So please go to the YouTube, I gave the link, YouTube CuroChat channel, and then also share it and add your other friends also. Thank you so much, and we'll meet tomorrow morning at 9 o'clock. Thank you.